Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humour and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
Good afternoon, everyone. We have a treat for you today, none other than Jackie Piasta. She is a self-proclaimed millennial-pausal woman who is rewriting the rules of midlife women's health, a board-certified women's health and gender-related nurse practitioner, a certified menopause practitioner, podcast co-host, and founder of Monarch Health. Jackie brings over 15 years of clinical expertise to every conversation. She serves on the Medical Advisory Committee for the National Menopause Foundation and several other committees for other leading women's health organizations, while also using the power of social media to reach women beyond the clinic walls. Welcome, Jackie.
Welcome, Jackie.
Thank you so much for having me.
It's so lovely to have you here. We all love you, and we've all learned so much from you over the years. So it's a real pleasure to have you here today.
Well, thanks.
One of the things we wanted to talk to you and ask you more about was your DNP that you're doing at the moment, because what you're doing is so interesting. It's about setting up a menopause clinic within a primary care clinic, isn't it?
Yeah, so probably the the best thing about it was that the primary care office I found actually wanted to do it. And we're very motivated to do it and so found the need. So I think that was really kind of serendipitous in a way. But I think that we're all recognizing and that the need for menopause care is too big for the OBGYN office, right?
Mm-hmm.
So essentially what we did is we implemented quality improvement work where essentially you find a problem and then you try to implement reasonable measures to try to fix it and see if it can be adopted without being too much of a train wreck. And then sustaining it is the biggest hurdle, right? Like keeping it going after you're not there to baby it anymore. So and when we look at the literature of what some of the gaps in menopause care are actually like at point of care is basic stuff like just screening women for menopause and just symptom screening. I mean, like how basic is that? We screen for so many other things. And yet first of all, our screeners are really outdated. We need new screeners. We're still using screeners from like the 1970s. If we're even using screeners, that's where they're from. So one of the problems is it's really hard to get a screening tool that validated, to actually validate it and make sure that it is acceptable to use them in a large population. And so we haven't updated the screening tools in many, many, many years. And so a lot of them are incomplete. So like the one that we really like is called the Menopause Rating Scale. It has 11 categories of the top menopause type symptoms: brain concerns, vaginal concerns, hot flashes, night sweats, of course, all those. But it's missing like joint pain is, missing what, our friend and colleague, Dr. Von der Wright, and their paper that they wrote on the musculoskeletal syndrome of menopause. So it's missing that. And then there's another screener out there called the Green Climacteric Scale, which is really nice too, but it's also missing some fundamental things. And so I actually, for this project, created my own screening tool, and I called it the Meno 10. And so the Meno 10Q, and it's 10 symptoms of menopause. And we broke it down, vasomotor symptoms, joint pain, brain fog, difficulty concentrating, those types of things. Oh my God, there we go. There's my brain fog. Sexual health symptoms like vaginal dryness, urinary complaints, pain with sex, and a lot of those typical ones that we hear about. And then we broke it down even further. And so another hallmark of this is making sure that your care is patient-centered and you're involving the patient in all aspects of the care. So not everybody wants to discuss their menopause things. I think that's one of the best things about us. One of the most important things about being screened for something is we can be screened for it, but whether or not we want to discuss it further are two different things. And so also part of this screening tool that I developed is whether or not the patient wants to discuss these symptoms further. And so that kind of ended up prompting whether or not we took it one step further in the project. But it was really cool, just implementing screening. So we implemented it to all women 40 to 65 years of age that came in for their women's wellness exam. Yep. And it was really neat because so many of the women reported back, they didn't even know half the symptoms were part of the menopause transition, or they were so grateful that they were being screened for it. So that was a really cool part of the project. So something so simple as just asking people a question or to check a box.
Did you do a number, in the green,
Sure.
Anything more than 15? Did you devise a number system to sort of be able to explain to women, how deficient they were?
Yeah, so I did stratify it similar to the way the menopause rating scale is, where 0 is not concerning or only very minimally concerning, and then 4, all the way up to 4 was debilitating symptoms. But I didn't, and then I did stratify it as far as anywhere from a 0 to, let's just say 8. I can't remember off the top of my head right now, but 0 to 8 was mild symptoms. 8 to 15 was moderate, but we didn't really utilize that. We utilized that to say, okay, was the symptom burden amongst our population mild, moderate, or severe? For this target population, it actually was a moderate symptom burden. I think the average person, it came around a score of about 12 to 13, which equated to a moderate symptom burden. But our population was actually ended up being on the younger end. So most of the people in our study in the quality improvement study were ages 40 to 50. And so and actually leaning more on the 40 to 45. So it makes sense that the symptom burden would have been relatively mild to moderate. But our biggest conversion ticket item was whether or not they just wanted to talk about their symptoms more. So it wasn't whether or not the symptoms were, of course, debilitating. Yes, we were flagging that. But even if the symptoms were mild, we were still just looking at whether or not they wanted to discuss it further. And if they wanted to discuss it further, then we did. And then we developed we called it a pre-planning tool. And so the whole purpose of the quality improvement project was to move women into a dedicated menopause visit away from their wellness. So it was to start the conversation or facilitate the conversation that was already going to be asked, right? Because one of the biggest things that healthcare clinicians, their skin crawls, right, is when somebody's coming from just a basic wellness check and they want to discuss other things. And it's not because we're not empathetic, it's because we're burnt out and we have too many other things, right, on our schedule. We just simply don't have the time. So the whole purpose of the visit was to start the conversation, make it be patient-centered, and then move those individuals into a menopause follow-up visit. And so we gave them this patient pre-visit planning tool to prepare them. And it basically had information about menopause. It had what are your goals, what are your priorities, etc. And then when they moved into a follow-up visit, it sort of was already a roadmap for how to get through that. And this is insurance-based medicine, right? This is not concierge medicine where we can spend an hour. So it was all about making it as facilitating that discussion as best as possible within the confines of an insurance-based model.
Mm-hmm.
That's
So they went in
incredible.
for their physical. Were they given it to in like the waiting room when they went and checked in like the kiosk, or was it while they're in the room waiting for the whatever clinician to come in and then they were filling it out?
So we did it where when the medical assistant brought them back for their vital signs, we gave it to them during that time. But
The rooming process.
right. But there were some like things that we couldn't do. Like ideally, I would have loved to have it electronic and send it to the patients the day before, right, via our like pre-visit.
Yeah.
But I just couldn't do that for the purposes of this project, the doctoral project. We had to have everything in writing. We had to have like paper trail of everything. But in the future, that was one of kind of the future considerations, was making sure that this is part of your pre-interventions, just like the GAD-7 and the PHQ-9, which that's the Patient Health Questionnaire 9, and then the GAD-7 is the General Anxiety Disorder Screening Tool. And a lot of times we have patients fill these out before. So that was the whole thing, is just incorporating it into that model. But we did it at point of care when the medical assistant was running through.
That would be easy for them to do that, before, because I think about like Medicare Wellness, they're always sent their questions before, when they like the day before. And if they remember, they'll fill it out online, or, just prepping for anything in an insurance-based model. Most of like your bigger systems will have all of that electronic. So then you'd know that you'd have based on that, do your wellness visit or whatever. And then, okay, let's make that follow-up visit for our menopause or perimenopause visit.
Yeah.
Like in depression, people don't realize that a change in their sleep, change in their appetite, and irritability can all be connected to depression, so just like that, especially boiling it down to 10 questions is great, as opposed to the green climacteric, which is 20 something, 23 questions.
Yeah, it's correct. Yeah, right. So it gives us more than the MRS, right? But we're lacking a lot in the MRS. So anywho, it was great. I mean, it's simple stuff. This isn't like rocket science. We're not like, but it doesn't have to be difficult or catastrophic for it to make a huge impact. And that was one of the coolest things, like I said, is just how much the patients were so grateful for the conversation to be started, and to have some just a questionnaire listing symptoms was highly thought of in terms of like information, providing information. So
it's a very low bar.
Right. And not reinventing the wheel, like our little planning tool that we, the clinicians, once the patient said we want to discuss these further, we used this planning tool. We gave it to them. They sort of started it and they took it home. There was a QR code to already the Society for Women's Health Research has a beautiful, like 30-page PDF packet all on menopause, and it was linked to that. And so the tools are out there. We just have to know where they are and guide our patients into those so that they can get good, reliable information. Because as we all know, menopause is one of the biggest areas of medicine that has muddied itself all up.
Yeah.
Were those clinicians then prepared for those follow-up visits? Did you find that they were adequately trained, or did you find that there was
so that's a great question. So I would say is about 50-50. That was one of the areas of the audit tool of the auditing. So I had to audit everything. So, once this is all, you have to go in and actually see like who's not getting it, who wasn't given the questionnaire, who wasn't given the tool, who didn't schedule a follow-up visit when they marked that their symptoms were high up on the burden scale. And so you had to go through, and I actually,
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
Back to the test of change, Jen.
So what we saw initially is that those questionnaires were being handed out and the conversations, I think, were happening, but they weren't being documented in the chart. And actually, there's another study out there that actually Stephanie Fabian, who is the medical director of the Menopause Society, they have a paper, I want to say from 2023 or 2024, but basically it talks about how documentation of menopause symptoms is nowhere. There's no documentation. And this was through the Mayo Clinic. They looked at the Mayo Clinic records. And so that was a huge thing that we were finding is nothing was being documented. Well, we all know when patients come back for a follow-up visit, if it's not documented, I mean, we need that. Like, why are they here? Let's go back to the last visit. Let's document this. So part of it was helping with that and facilitating that. And we added, again, not rocket science, we added a smart phrase in the charting system that said, this was discussed, you literally type in the number on the symptom burden in the blank space and then patient blah, blah, blah. But as far as whether or not they were educated, you could certainly tell which ones were less comfortable than others because there were more misses. There were fewer follow-up visits. So certainly. And then, so another one of the tests of change we had was an in-service. We had a teaching in-service. And then we also I built out a big folder for them, which had a toolkit, essentially, the closest thing that we can get to an algorithm. And that's another problem that we have in menopause care is everybody wants drop-down medicine. And menopause is one of those things where there's not necessarily a right way to do something. There's a lot of wrong ways to do it, but there's not necessarily one right way. And so I think people get really tripped up on, we go to these conferences or we go to these lectures and they teach us the concepts of these medications but then we're stuck with a patient in front of us and we're like, wait, but how do I actually do this? How do I actually prescribe for this person? So we sat through that and we did some training. So I would say 50-50, Christine. We had about 50% of the clinicians were pretty well versed and comfortable with it. And it was pretty obvious which ones were maybe not, needed a little bit more hand holding.
So you almost need it in, because I think, in my primary care, there are templates for an annual wellness physical for a female. And so if it's like 40 and over and they'll do it by age, you almost could have it like part of that template. So you don't forget to ask the question and you kind of like F2 through the whole exam and these, phrases will come up. And that would be a nice way, something like that, where, you're asking about periods, you're asking about your PAPs, you're asking about mammograms. And then it comes down with, okay, hot flashes, night sweats, mood changes in periods, whatever it is. And it would help to prompt clinicians then to ask the question,
Yeah. I mean, we have to find a way. I mean, I know us all here, we have our small private practices and stuff, but we do have, we have to find a way in order to jam this round peg into a square hole a little bit. I mean, we have to figure out how to get menopause taken care of in an insurance-based model, at least while we still are working within this structure. And somehow we've got to do it. And it's not going to look like what it looks like in an hour-long concierge visit. And that's different. That's a different sort of medicine. But it can also be done in this way, but we have to be strategic about it. And we have to be a little crafty, right? And find ways and tools in order to facilitate within the constraints of the
and it's going to be more than one visit, right? I mean, that's going to be really what it comes down to with patients is just saying, listen, we have to do all the things. We have to first identify you. Second, then we need to educate or get you to someone if it's not in the same area, or to maybe if they're to practice with more than one clinician. If someone's doing menopause in there, then we get you with them. And it's going to be more than one visit just because of the time constraint, to talk about the education, the risk, the benefits, all the options, all the things that, and that we can do in an hour or hour and a half or however long the initial consults are. This is going to be more than one visit. And I think once they know that, they're okay with that. They accept that a little bit more, knowing that they'd rather come back more than one time so they can get everything that they need.
Yeah. Before we get that far, though, we have to there has to be some mandated education of clinicians because most people out there do not, we still hear it on a daily basis. I don't believe in hormone therapy. I mean, our patients tell us that they've been told that all the time. I don't believe in hormone therapy. So how do you get to a place where you're asking about it at each visit and able to manage it in an insurance-based model when you've never even been taught about it? We have to have some type of mandated education for clinicians.
Yeah. No, I mean, 100%. It's got, I mean, it has to have representation on the board exams. I mean, I think that's another big issue is that there's not good representation. I know for sure on ours. I mean, I would say, Christine, we have fairly decent representation on our board exams, but it's still not great. I mean, I think the women's health nurse practitioners do a fairly good job of having some menopause curriculum. But in all fairness, we don't have to study surgery. We don't have to study, pediatrics, delivery medicine. So for our obstetric gynecology colleagues, in all fairness, our board exam can focus a little bit more on those areas because we don't have to focus on some of these other areas. But
I know my daughter of family physicians, they send us 25 questions a quarter, so 100 questions a year. And I've been doing them for years. And this past year, maybe the last quarter or the last quarter of last year, there was one question on menopause and the answer was completely wrong.
I'll have to look for that too, because we do the same thing every quarter.
Yeah. And I just sat for my research for NCC, my recertification exam. And I was really glad that I was a menopause practitioner because almost the whole thing was midlife and menopause care. And it was the first time, I think I've said this before, it's the first time ever I did not owe any extra continuing education, not one extra hour. Because it's all based on how you score. But, I don't know if everybody saw Corinne Menz. Everybody probably did her interviews at ACOG of all of those students. And I was thinking, okay, we are finally hitting our stride. Like there is so much, discussion and, many of us are educating nurse practitioners and physicians. And to hear the 3rd and 4th year medical students say that they didn't know what GSM was, genitourinary syndrome of menopause, or, anything about libido, and they really didn't get any menopause training. I thought, oh my goodness, we're not going to see the light of day for decades.
Yep. Well, my daughter's a 2nd year med student and they've had 1 hour. Now it was done by an MSCP. I looked at it. I looked at her lecture. It was better than anticipated, but it was still 1 hour. And so she'll probably not get any in her 3rd and 4th year rotations unless whoever she rotates with actively is involved.
Yeah. It's getting harder to defend, isn't it? It's getting harder to know that there are guidelines out there and algorithms and all these courses, and they've been around for years and years and years. And yet clinicians don't know about them and aren't using them. It's getting much harder to defend that to your patients.
Well, it needs to be in some of those courses that are, incentivized for them to take, right? So it needs to be if it's family medicine, it needs to be part of, at least for me, for osteopathic, it's ACOFP. It needs to be they have conferences once or twice a year. It really needs to be part of that curriculum too, and not where you have to seek it out and spend, how much money have we all spent getting extra training in sexual health and menopause health and midlife care, right? And so, and we did it because we love it, but they're not incentivized to do that.
No, I would have had to leave work unpaid for a year or more to learn what I've learned over the last few years. If I was going to throw myself into it and really just learn about it. It's not easy, and it's a long process. And it takes seeing a lot of patients as well, because you learn so much from your patients coming back to you, telling you how they're doing. So it's not even something you can rush. It really has to be from day one of your training that this is incorporated.
I think there's another really essential concept within all of this too, is that I think that there has some degree of humility that has to take place amongst yourself as a practitioner. because everybody asks me, well, what was your best course that you ever took? Or what, and I'll always say the best course I ever took was sitting in the exam room with my patient and opening up my ears and my heart, not to be too cliche, but like if you open up your ears and your heart and you sit there and you listen, your patients will teach you. They'll teach. I mean, I still remember back to like pathophys in my first ancient history and physical class in NP school. And the instructor said, if you listen enough, your patients will tell you what is wrong. And it's like burned into my brain. That's like day one H&P class. And nothing has changed. Again, this is not rocket science. If you just sit down and you listen to people, they will tell you what is wrong and they will tell you how to make it right. You can, and I feel like it's so true, especially if you are going like the menopausal hormone therapy route. There's not one way to skin that cat. There are a million different things. It's one of the hardest things about, even let's just take our friend estradiol. We have 6 different doses of patches, 3 different doses of oral pills. We have 4, 5, 6 different oral pills to choose from, but we've got a patch, we've got a patch that's a combination patch and a regular patch. Oh, but now we've got this weird spray thing. Oh, we've got a ring. To us, we know this, we know these therapies like the back of our hand, but to somebody who's not, but most of how you get good at this is just listening, listening. How did that go? How did that work? And not being afraid to not to seem too flippant about it, but to play around a little bit and to have this co-creation, make this partnership with your patient and trust women that they know their bodies enough to be able to tweak doses here and there. And these are really hard concepts for those of us that are trained in a traditional medical model where we
tell them this is what you have to do.
It's very uncomfortable for us.
It is.
Don't change your meds. Don't
your partner.
Dose, don't do right. And so
when you're like, I'm a partner with you, they're like, what?
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
Yeah, right. It's a really, really hard concept.
We see some of the doctors in academia, right? And they say, but the studies don't show this, the studies don't show that. And our point is, well, we're seeing patients. And our patients are coming back telling us the same things over and over and over, past 12 weeks, past that placebo period, months and months down the road. And so are we supposed to not trust our own clinical experience and expertise and our patients? So we shouldn't trust what our patients are telling us. We should only trust what these small, tiny studies have shown, many of which are years old. Is that what you're saying to us? No. Medicine is an art and a science, right? It takes all of us to give us the information that we need. And it's driving me a little bonkers, honestly, lately, with some of the peeps in academia saying, no, don't trust your patients, don't trust your experience. Just go by these guidelines, go by these papers. Does it bother you guys as much as it bothers me?
Because guidelines, people, providers act like guidelines are laws because they're afraid of being sued. And they don't protect you from being sued. Being nice and listening to your patient, that protects you from being sued, right? Yeah. And, I don't even think you could put midlife care in a good guideline because there are, like, as Jackie said, so much individuality and so much choice. And it depends on what, your patient wants. But you certainly are not going to optimize their hormones and get them feeling their best if you put yourself in a little box of this is the only things that I can do. Boxes on guidelines are really small. It means there's not a whole lot of variability. There's not a whole lot of choices.
No, I think, and we get so, I think we've gotten ourselves in, and again, it's not just one reason why we're in a space like this, where we've got a big hill to climb to get ourselves. There's multiple different layers, like the societal context, right? The differences in philosophy, medical philosophy, right? Like we don't all agree. Like what other area of profession does everybody agree all the time? Like how many, that's like the whole practice of law, right? Is that like the law is the law, but the interpretation of the law might be different depending on who you are. Same for other business, economics, all these other professions. Like I don't know that it is so taboo for people to be like, yeah, I have a different opinion than you, or I have a different view. But for whatever reason, when it comes to medicine, these medical guidelines are thought to be some freaking type of like Rosetta Stone. And there's no way to read between the lines or to like apply it in a real world setting. That's another thing that I always tell my patients. I'm like, I love randomized controlled clinical trials. We love them because essentially you take a placebo and you take an active pill and you give it to somebody and you see if it works. But these are Petri dishes. People don't live in Petri dishes, right? Like we have, you're being watched, you're coming into the office, you're in a clinical trial. You don't just get like a secret like serum injected into your body that you magically forget you're in a clinical trial. Like there's influences on these as well. That's why studies have limitations and certain things and they're analyzed. So that's the whole point of these clinical trials, is for us to take the information that we learn within these clinical trials and then apply them to a real world setting. That's the whole practice of medicine. So I don't understand why we disagree, why there are such, contrasting thoughts, like schools of thought going on right now. It is really infuriating. Aoife, to your point, it does make you feel a little bit like you're living in a twilight zone a little bit sometimes.
Yeah, I did hear a doc suggest the other day, we could do a study on giving women vaginal estrogen and giving them a placebo and then doing a trial on that to see if that cut down on things like UTIs. And I was thinking, but a woman would know within a week or two that she was on a placebo. I mean, estrogen is so amazing. She would still be having all her symptoms. There's no way she'd keep putting vaginal estrogen in 2 or 3 times a week and it not working. There are limitations to these randomized placebo-controlled trials that we can do. And then there's ethics involved as well. Is it ethical to give a woman a placebo when you have a medication that can protect her heart and protect her bones and everything? So there's ethics and morals involved as well. And again, if we wait for all of these studies, these perfect studies that are never going to be funded and never going to happen, we'll all be dead. We'll all be long dead. So will our patients.
Yeah. Well, there's certain things that we just don't need studies for. Like we already, we know these truths, right? And what harm are we? Why partners do we need a randomized controlled trial of vaginal estrogen for a UTI? We know the answer.
Yep. I know. And if there's one more study on does vaginal estrogen work for, does it get absorbed into the bloodstream, I'm going to lose my mind. There must be 300 studies on that now about absorption of vaginal estrogen into the bloodstream. And we know the answer. Like, please stop spending our money on that.
Yeah. Like I was saying, I think a lot of it, I wonder, was some, of the clinicians that are on one side and the others on the other. If again, it's being afraid to partner with your patients, right? So, it's not like a paternalistic relationship. We're partnering with them. We're helping them. We're giving them all of the information and knowledge that we have, our opinion aside, unless they ask for it. And in hopefully an unbiased way, and saying, every single day I see a patient, I say, what are your thoughts? What are your thoughts? I want to, because I truly want to know what their thoughts are on this. What do you want to do? What are your thoughts on this? And I can tell you every day, at least one person is like, what do you mean? You're the doctor. No, I am. I'm here to help and to facilitate you, but and I'm going to give you all the information that you need. But, we need to be partnering with patients and giving them the tools to make these decisions for themselves, because when they have all those, I do agree, and I know it's been said so many times, they can make really great decisions for themselves when they have all of the information. And I just wonder if some of that is that old way of thinking of like, I'm supposed to tell you what to do, and these are the guidelines and that's the law, instead of here are the guidelines, this is what we go by, these are options, these are off-label options, we are in a partnership together, and let's make this decision together. What are your thoughts?
Do you find, Jackie, that by the time a patient comes to you, they've already seen quite a few other providers?
I think it's the nature of my practice is not within an insurance-based model anymore. And so I do feel like by the time most of my current patients have come to me, they have exhausted other options within an insurance-based model of care. So most of the time I am, the second or the third or the fourth opinion, but it's not always true. They're not always coming from the insurance-based model. Sometimes they're coming from, again, the grifters and the pellet mills and the wellness practices, which, again, not all wellness practices are bad, but some are unfortunately ill-informed and are taking our patients down roads that frankly just are unnecessary. So I get a lot of second opinions. Now, prior to opening up my practice 3 years ago, or 2 years ago, I worked in an insurance-based model. So I did menopause within an insurance, and I always say I'm the unicorn. I'm the nurse practitioner that was hired in an OBGYN practice to only focus on menopause. My physician bosses weren't breathing down my neck to see the pregnant patients and the wellness exams. And I literally had to go ask the manager to let me do wellness exams because my menopause patients would get so attached to me, they didn't want anybody else to do their wellness exams. So I would say, okay, 1 day a week, I'll do wellness exams and IUDs and general stuff. But that's a unicorn. You can't get higher. I mean, I remember when we moved, my husband's in the Air Force. So we moved, and we moved from where I was living in Arkansas, where I had my job as a menopause NP within a big OBGYN practice, to Atlanta. And I started interviewing at a couple of OBGYN clinics in the area. And I'm like, yeah, I'm a women's health NP, but I do menopause care. And I've been doing that, exclusively for the last many years. And so many people just laughed straight in my face. They were like, absolutely not. No, we control your schedule and you have to see everything and everyone. And so again, this goes back to kind of the systemic issues, right? Is that insurance-based OBGYN care, there's so many demands. There's so much, and same for family practice physicians, internal medicine physicians. There's so many demands that fall on our plate. I think this is why a lot of us are sort of picking ourselves up out of that model and going into these different practice environments because of that. But a lot of my patients, even in that insurance-based model, Aoife, I would get a lot of second opinions, or I would get people that already had gynecologists and sort of had their well woman exam with their gynecologist and sort of knew they weren't going to get very far. And so they would keep their gynecologist, and then they knew that I only did menopause care. And so they would make an appointment with me for that.
Yeah.
And that's just kind of how that lived. But that is not a typical thing that exists. I mean,
when I was in private practice, it was same time I really started focusing on midlife and menopause care. And the only way that I could work it was to see the last patient before my lunch and the last patient of the day, which meant I never got lunch and I always left late because it required more than the traditional 15 minutes or 20 minutes appointment time.
Oh, so,
yeah.
Well, and that's the part I left out too. I mean, we were paid, and not to get too in much, but I think it's important for people to understand the economics of this, right? Why this is the way it is. And, my colleagues, I had 7 physician colleagues and 10 advanced practice colleagues. So nurse practitioners and physicians assistants. And we were paid, the advanced practice clinicians were paid a salary based on an hourly rate. We were paid a salary, and then we were bonused as a percentage of our revenue. So what we brought in, and we were given we were entitled to a percentage of what we made above our salary. And guess who didn't bonus? The person that was only seeing the menopause patients, because you can't see as many patients because the appointments take longer. Even if you're trying to rush it through in an insurance-based model, you just can't. I mean, when a woman's sitting in your office crying, you can't, you just can't.
Right. Sorry, the next
And so we saw less patients. We didn't do procedures. You make money in medicine off of procedures and certain billable codes. And so that's a lot of people say, well, why is my person not going to get trained on this? Why are they not motivated to do more of this? Or why are all of you people abandoning ship to only take cash? And it's like, because the math doesn't match. And it's unfortunate. It's really broken. And I don't have the answers. I don't have a master's in business administration or a degree in economics. I don't have the answer.
Damn it, Jackie. That's why we brought you on.
I know. I'm sorry. You're going to have to get an economist for that. But, I think it's frustrating because I've lived both worlds, right? I live the concierge medicine world now, and I've lived the insurance-based model. And
even in our, concierge model, all of us have pivoted a little bit in how we, in our pricing structure and the way that we set up our programs and delivery. All of us starting originally with fee for service and then pivoting to membership. I think that's something that bodes some discussion, because I think, patients are a little surprised when when it's a, monthly membership fee, and why we chose to set up things like that. Which, truth be told, is a little bit more expensive than the fee for service. Jackie, what are your thoughts on pivoting to a membership model, and what did that do for your patients?
Of course. I think anytime you talk about, right, it's like the standard stuff is like, you don't talk about religion, politics, or money at a party, right? That's all the good manners that we learn from our parents and our grandparents. So it's always awkward talking about money and financials and things. But, it's a business. And at the end of the day, we have to remain as intact. We're human, right? Healthcare workers are human. And I think we saw, right, the extent of how we could push ourselves in the pandemic and what that did to many of our colleagues, and just that we are human and burnout is real. And, even if you are in a cash-based model, it doesn't mean that you're immune to being burnt out. I think most people in healthcare are empaths at heart. We are givers. We want to take care of others. I know, and I no shade on my doctor colleagues here, but nurses are really notoriously terrible at doing things at the expense of themselves. And then women, we are like notoriously awful at doing the expense. I think that's why the female physician burnout is worse than male physician burnout, because we take it home with us. We don't let it go. And it's not like water off a duck's back. I think I'm generalizing here, but a lot of our male colleagues are like, Aoife, I know you've said this about your husband. Like he would, it's the emotion is just less, right? We get very emotionally attached. And so what a lot of people don't understand is that what's unique about menopause care, and why probably a lot of people roll their eyes at menopause care and don't want to get involved in it, is because there's a lot of care that happens behind the scenes and outside of that direct encounter, right? And I think, Christine, that's kind of what you were highlighting on, is why so many people are pivoting to a membership-based model, because so much of it happens outside of that 15 to 20 to an hour long amount of time. And there's only so many messages on a patient portal that you can answer having good attitude before you're just over it. And as much of a good of a person as you are, or much well-meaning as you are, I mean, at the end, there's so many hours in the day. We all get 24 hours. That's it. Right. So again, this is an evolution. I think we're all, one of my best friends is a physician assistant or associate colleague, Christina Saldana. And she said, I remember when I talked to her about my business model, and she's mentored me a lot through this. And she said, Jackie, we're all just assembling the car while we're driving it, you're all putting it together while we're driving it, trying to figure this out. And because we were all trained and brought up into the medical field within this insurance-based model, we don't know how to do this. We're not business people, unless you've got a business degree along with your MD, which some people do. We don't learn how to be entrepreneurs. And I think that's why you're seeing this move from physicians either going, or physicians and advanced practice clinicians going to kind of what we have done, and this small mom and poppy kind of like concierge-based model, or we are just cogs in the machine and going to large privatized hospital-based systems, and we just go and we punch the clock and we leave, right? I mean, that's what medicine is turning into.
I was shaking my head there when you brought up my husband, not because of my poor husband, but because of that topic of the difference being in medicine is between being a woman or a man in this field of medicine, right? It's very difficult. Like, these studies have been done. Patients expect more empathy, more time from a female clinician than they do from a male clinician. My husband has been in medicine the same amount of years as I have, and no one's ever called him Dave. They always refer to him as Dr. Cosgrove. So do all the staff, whereas I'm often referred to as Aoife or, other things.
Yeah.
It's just, there's a stark difference there. You were saying, the burnout rate and I hate that word as well. I know we all do, but like that moral injury or rate of burnout is so much higher for women than it is for men because the expectations are so different, which is not fair, really, is it?
Yeah. Well, and it's the mentality, right? That if you are aware of your value and you ask for that in dividends financially, then you're not a good person, or you're doing something wrong, or you're taking advantage of somebody else. And so these are all very difficult concepts that I remember when I first went in to start my bit, and I charged like 100 and nowhere near what I ask for now. And I remember sitting in this exact chair, like bawling my eyes out, and my husband just being like, "What the F, Jackie? Like, what is wrong with you?" He like no emotional attachment to this. He's like, "You're offering a service. You're providing a service. But again, we are in a very troublesome environment because the insurance-based model has totally built a Ponzi scheme out from under us. And we have just all been led to believe that is the way things are done. And so how we get ourselves out of this pickle, Aoife, I don't have the answer, but it's hard. It's all very difficult, challenging concepts. But I do think that for those that we can partner with and take care of, and, we can sort of pass that on in other ways. So, right, there's through these podcasts or through a social media presence, or even through educating those individuals that are our patients. And then they can go back, tell their friends, and their friends can go to their insurance based. And the more we hear it, the more it gets sort of force fed down their throats. We'll get there. And that's why we can't be deterred by this. We just have to continue to be obnoxious and be loud. There's other ways to kind of contribute, I think. But again, I can't be of much help if I'm not around, because I allowed too much of myself to be expended along the way.
And you leave altogether.
Yeah.
Outside the realm of medicine, what do you do in your spare time, Jackie?
So my doctorate program has robbed me of a lot of my hobbies.
When did you graduate, Jackie?
Yeah. What?
When do you graduate?
We don't graduate until September, because it's a weird, they do one graduation a year because they have rolling admission. Yeah. So they graduate all of us at the same time. But I am done in 3 weeks. Thank God. Yes. Yay. Yes. So yes.
And then the fun begins?
Huh?
And then your fun time, you go back?
And then my fun time begins. So I went to hot yoga this morning. So that was exciting. So I actually in my past life was a yoga teacher. So I love to do yoga. I love to garden.
When was the yoga teaching? Was that after college, or?
I'm just a glutton for punishment. It probably was during COVID. It was during COVID. Yeah. So I probably got certified as a yoga teacher in 2020, because I can't just go to a yoga class and then not be I want to learn all the things about this and then go to a training and all the things. Like, we can't just like be normal, right?
No.
So that means when we go to the Menopause Society meeting in October, you and Rachel Frankenthal need to
have like
do a
yoga
class
party.
for you guys.
Yes.
We should, a menopause yoga meeting.
Yeah. So I am a yogi, quote unquote. So yeah, I don't have a ton of hobbies. I like to travel and go places with my family, and Christine and I bond over our golden retrievers, even though that's not a hobby, but if you know, you know.
There's a lot of exchanges of videos and
yeah, I like to drink wine, although perimenopause has not been very friendly to me in that hobby. So
It's not fair.
It's not fair at all.
Where are your dogs, Jackie? Tell me about your was it Ruby?
My dogs are somewhere else. They were barking earlier.
The one with the wine fiasco.
Oh, there's always wine everywhere. That's why we can't have nice things, because their tails just knock things off tables all the time.
And your girls keep you busy, right? You have two little
girls. 2 little girls who give me gray hairs and
give you
make me happy and fall at the same time. Yep. So,
I have to get every 5 weeks with mine.
Yeah, it is. We're all just trying to get through, right?
Mm-hmm.
Yes.
Yeah.
And I'm not super fun. I wish I had more fun. Everybody always asks me, "What are your hobbies? What do you do?" I'm like,
"Oh, I'm the same." Yeah,
I'm the same way. I'm always like, a lecture. I was like, well, I listened to a new lecture.
I know. I'm like, I like to make PowerPoint.
Canva.
Sorry,
is that
don't
not
touch me. I was the kid that, like, during grade school, when they were like, you need a 3-fold poster board to make a project, and I was like, I know, I'm really creepy. But no, I know it is weird when we love our job, right? We love what we do. And so
we're total nerds, total menopause nerds.
I'm always text them. I'm like, I totally nerded out over that lecture. So good.
Yes.
All the time. She listens to everything on 1.5.
1.5. Yes. So when it's on 1, I never
finish it. Rebecca's listening.
I know.
Yes. Yeah. But
well, it was great having you, Jackie.
Yeah. Yes. No, this was a great conversation. Thank you for provoking such dynamic and a little bit controversial, but I do think it's important to talk openly about this stuff, because I feel like a lot of us don't, and it's kind of why we ended up in this place in the beginning, right?
Yeah.
I was going to say, we've been so busy with our backs turned taking care of patients that all this other stuff has happened while we've been doing that, and now we have no control over anything anymore, or we're just cogs in the wheel.
Yeah. We're going to take medicine back. It's ours.
Yeah.
That's right.
Taking it back.
That's right, Dingo. We have to take it back. We spent a lot of time in it.
For sure.
Right. Well, it was great having you, Jackie. Thank you so much.
Yes,
have a great rest of your Sunday.
Yeah. Bye, Jackie. Thanks.
Bye.